Right, guys, so let's make a start. So it's 5 minutes past 12. We may have some people joining us late. For those of you who don't know me, my name's Aaron. I'm one half of Mofo Body Mechanic, which is a injury rehabilitation clinic based in Batley, not far from Bradford and Sheffield. In my other guys, I run a mentoring scheme for new grad therapists. And in my other guys, I'm a senior lecturer at LBU, Leeds Beckett University, for those that are not Leeds. What's the other one? London?
Oh, I don't know.
I don't know, whatever it is, London Met. So we're going to talk a little bit today about managing tendon injuries. And again, I'm going to try and keep this as complicated or as simple as it needs to be. Hopefully you've all seen the pre-reading. If you're a member of our closed Facebook group, and if you aren't, what do they do to get onto that?
Just drop us a message on Instagram.
Or Facebook.
Or Facebook, and I'll add them, I'll send the link.
So if you want access to us and access to the other members of the group, closed Facebook group is an opportunity for us to share knowledge, research papers, best practice, that kind of stuff. So hopefully you've accessed the Tendinopathy Continuum paper, which I put up there earlier this week. My preparation for this webinar has been watching videos on YouTube of how to make myself look prettier on camera. So I've done very little in terms of reading about tendinopathies. I've been trying to make myself look better on camera, which hasn't been an easy job. Could I just ask kindly if you could all give us a shout out on your social media pages? I'm trying to spread the love, or we're trying to spread the love as much as we can whilst we're in this lockdown phase. It would be nice if we all come out of this situation having upskilled, gained a bit more knowledge for the betterment of our clients. We plan on doing another one of these. So if you've got specific things that you want to ask, and this is more kind of like topic areas. So if you want to know some stuff about muscle injuries, if you want to know stuff about back pain management, if you want to know stuff about managing ligament injuries, if you could drop us a message on the closed Facebook group, and then we'll compile a list of the common themes with the intention then of running another webinar or several other webinars through the course of the next few weeks. For those of you interested in upskilling your anatomy knowledge, so a colleague of mine, Chris Knott, is running an anatomy club, which takes place on a Wednesday at 2 p.m. So it'll be good to see you all there. I think I'm co-hosting again this week, and it's muscles of the shoulder and upper limb. Right, so moving on. Tendon injuries, that's what we're going to talk a little bit about today. Now, according to the research, 30% of musculoskeletal injuries seen in primary care involve tendons. And I think there's several issues around that in terms of, GPs, doctors, nurses diagnosing tendon injuries. It's quite a complicated process. So I actually think for my own clinical practice, and probably for those of you that work with, similar population groups, I think that's probably closer to 50% of what you're going to see in clinical practice. It's most common in athletes, and it depends on the region of the body where you've got your tendon injury as to the type of sport that you're involved with. But at Mofo Body Mechanic, we tend to see a lot of people involved in the fitness industry, a lot of bodybuilders, powerlifters, Olympic weightlifters. So we tend to see, I think, a higher proportion of people with tendon problems. And I'll talk a little bit about this as we go through the presentation. Now, there is seemingly an increase in the prevalence in the sedentary population. So you do find that, if your PTs working with your deconditioned clients, there does seem to be a higher predisposition towards those clients suffering from tendon problems. And I think the common thinking is if they're overweight, it's because they're carrying more weight, or it's the sudden change in activity levels. But there's a lot of misinformation around those things. And again, I'll talk a little bit about some of the reasons why I think people in the sedentary population tend to have a higher likelihood of developing tendon problems. Right, so terminology-wise, now you'll probably find when you look in your textbooks or you do a Google search, Tendinitis, and this is kind of the cultural starting point for most people, tendinitis is the most common term used for tendon injuries. Now, tendinitis means inflammation, that's Latin for inflammation, and I would like to propose that in most cases, that when you see your clients with tendon problems, it probably isn't an itis, an inflammatory process. Tendons often are asymptomatic, so until they reach a critical threshold, you tend to find that tendons are generally pain-free. So your tendon problem can be developing for weeks, months, prior to the onset of the pain. Now, as you know yourself, when you have an acute injury, something that's happened 2 or 3 days ago, you're going through this inflammatory process. However, because a lot of people are going to find that these things have developed over weeks and months, you're out of that inflammatory process and you're into probably more of a degenerative stage, tendons starting to break down and become weaker. So in most cases, tendinitis, by the time you see these clients, they'll be out of that inflammatory stage and they'll be into the disrepair or degenerative stage. Now, tendinosis, this is another term that's again commonly bandied around. This is degeneration of the tendon. So the ground substance, the matrix, all those structures, the collagen fibers, all those things that make up the structural integrity of the tendon, they tend to start to become less able to handle load. Now, that's not great because that's the role of a tendon. Essentially, it connects the muscle to bone, and part of its job is, as the muscle contracts, it moves the joints. But the other part of its job is load management. It absorbs some of the impact from, if it's lower limb, it might be ground reaction forces, it might be the force of the muscle contracting. So your tendon, once it starts to degenerate, then starts to become less able to handle loads. So contemporary thinking, because we don't know whether it's an itis or an osus, is to describe tendon problems as a tendinopathy, which simply means there's something wrong with a tendon, but we don't know what it is. We don't know whether it's an itis or an osus. Now, the paper I put into the Facebook group was Purdham's tendinopathy continuum. And in that, they've proposed a new classification of tendon injury. So they describe it as reactive, disrepair, or degenerative. And I think this is really useful when it comes to management, because if you're in the reactive stage, as we'll talk about later, there's certain things that you'll do to try and address the reactive tendinopathy. If you're in the disrepair stage, there's other things that you'll do. And then if you're in the degenerative stage, again, there'll be different things that you'll do again, all of which revolving around load management. Now, common sites, and I think you can probably echo these sentiments. So shoulders, elbows, wrists, knees and ankles, they're the common sites that I see in clinical practice. Shoulders, it's usually the tendon of supraspinatus. And if you've been following Chris's anatomy club, supraspinatus is the muscle that, one of the rotator cuff muscles, that goes from the supraspinatus scapula underneath the acromion, so it goes underneath the bony arch, and then attaches onto the greater tubercle. I'm just getting a message on my screen there. Now, as you overload that tendon, you start to develop what's called a painful arc of movement. So you get pain between 90 and 120 degrees. That's the most common in the shoulder. Elbows, well, it depends on the side of the elbow that's been affected. So you're either going to get what the layperson describes as tennis elbow, which is a lateral epicondylitis or epicondylosis, which is essentially tendinopathy of the extensor muscles as they attach onto the lateral epicondyle of the elbow. Or you've got a golfer's elbow, which is essentially the attachment point flexor muscles as they attach onto your elbow, the flexor of the wrist and the flexors of the fingers. Wrist problems, these tend to be more in terms of the tendon sheaths. So in your body, you've got tendons that don't have a sheath, and you've got tendons that do have a sheath. The tendons that have a sheath tend to be those ones that are close to bone. So if you think about your hands, back of your hands, the extensor tendons, there's sheaths around those. If you think about the feet, there's sheaths on top of the feet around the tendons that extend the toes. So anywhere a tendon that goes close to bone, there's a synovial sheath that wraps around it that essentially protects the tendon from the bony surfaces underneath. Knee problems, this is patellar tendon problems or quadriceps tendon problems. Again, we see a lot of those in clinical practice. And then ankle, it tends to be the peroneals, which are the muscles that run down the side of the ankle, the muscles that either the foot or the Achilles. I think that's probably the most common one. So, causes. If you think about managing your clients in, in a PT guise or as a therapist, there's various causes which I think contribute to the development of these tendon problems. So the first one is the dripping tap. And this is essentially those people are in the gym, training regularly 4, 5, 6 times a week, and that repetitive micro trauma, that overuse of the tendon starts to lead to tendon degeneration. It starts to break down, become less able to handle load, and then eventually it starts to develop pathological changes in its structure. Those are the common ones that you tend to see from your lifters. Those people have got, tennis elbow, golfer's elbow, patellar tendonitis, those sort of things. Another cause is the big bang. So you load up your bar, you do one super physiological load and one super physiological effort, and then that tends to start to cause problems from that point onwards in the actual tendon itself. So you've either got the dripping tap or the big bang. Now, there are unusual or uncommon causes of pathology that tend to lead to tendon problems. Things like diabetes, that tends to lead to more likelihood of developing tendon problems. Thyroid disease, that again tends to cause problems with tendon degeneration. Overweight clients, obese clients, you tend to find the tissue produces cytokines, which then tends to cause problems with inflammation in the system, which then starts to cause problems with tendon becoming inflamed. Super supplements, anabolics if you will. Could you all just mute your mics for us, please, guys? Take it out of this screen. So we've got your mics on. You just might just mute your mic. There's some scribbling around in the background. So what do I mean by super supplements? These are your anabolics. And yes, anabolics produce increases in muscle size. The problem is with your tendons is the tendon regenerates or hypertrophies at a much slower rate than the muscle does. So in those clients of ours that are enhanced, you tend to find they've got big muscles that are capable of producing lots of force, but the tendon hasn't yet caught up with the size and the strength of the muscle. And that's a potential problem as far as tendon loading is concerned. I think the other problem that I think is a critical thing as far as tendon development is concerned, or tendon problems are concerned, is this progressive overload approach, which is what we all adhere to when we're trying to hypertrophy muscles. Now, typically, you go into the gym and you might split your routine up as a push-pull legs, or you might be, on your bro splits, your chest, your shoulders and triceps. Fundamentally, because of the nature of the way that we have to fit those sessions into a weekly training session, there isn't sufficient time, if you're progressively overloading every lift, for those tendons to recover. Now, if you look at the world of athletics, most athletes, sports people, will have high tendon loading days, moderate tendon loading days, and low tendon loading days. And that's in order to give the tendon, which heals much slower than the muscles do because of its poor blood supply, a better chance to recover. And I think we don't do that in the fitness world. You tend to find that I think a lot of us think we're indestructible and that we can just push hard every single session. And I'd like to propose that even in that situation, you still need to be thinking about the health and the overall load management on your tendons. Just waiting for my slide to... Right, back there. So, signs and symptoms. A sign is something you elicit through testing. So when you're in a clinical situation and you come to see your therapist, the signs are things they're going to test for. A symptom is something that your patient complains of. Now, tendon problems, and again, you'll probably, as I'm talking through this, if you've got tendon problems, you'll probably recognise these stages I'm going to go through. So often in the early stages, they're asymptomatic. You know, you might find you're in the gym, you're lifting weights, unaware of anything that's going on pathologically in the tendons. You get home, after you've finished training, you might have a bit of an ache in your bicep tendon, you might have a bit of an ache in your shoulder, you might have a bit of an ache in the Achilles tendon. And after a day or so, that ache resolves and you're back to normal. And you think, oh, I got away with it, it's fixed. You then tend to find that it starts to become problematic more during the course of the day. You can feel it when you're going up and down stairs in the case of lower limb tendons. You can feel it when you're lifting your arm in the case of shoulder tendons. Again, once you've warmed up in the gym, you tend to find that the symptoms tend to resolve. And again, you think, okay, I've got away with it. I don't need to worry about that anymore. I can continue on pushing on with my progressive overload approach. Now, eventually, once you get to the next stage of your tendon disrepair, you find that your tendon then, after warming up, doesn't feel any better, and you're able to start to modify training sessions. You're now not able to do certain lifts because of the pain it causes. You're having to modify hand positions, and that's when your tendon is starting to become dysfunctional. Once you get past that stage, which is usually the point where people come and see me, and probably many of the other therapists out there, so they've had it for months, maybe even years, their activities of daily living, their ADL start to be affected. So now in the upper limb, they're lifting the kettle, that hurts their elbow. They're reaching up for a cup from the cupboard, that hurts the shoulder. They're walking, taking the dogs out, walking the kids to school, and that starts to cause problems in the lower limb. And that's typically how tendon problems tend to manifest. So often asymptomatic to the point where they then start to affect everyday activities. Now, from a testing perspective, if you're thinking about trying to diagnose these things yourself, there really isn't a gold standard as far as testing is concerned. So the things that I use in my own clinical practice will be pain on palpation. So if you think about the Achilles tendon, you often find once you've got past the early stage, the itis stage of Achilles tendinopathy, you tend to find you start to get a thickening on the Achilles tendon. It's usually about 2 centimetres above the calcaneus, the heel bone. So there's some pain on palpation. When you push onto the muscle, it hurts, or push onto the tendon, it hurts. And usually we use manual muscle testing. This is resisted testing to reproduce the symptoms. So in this situation, you need to know what the muscle does, what the actions of the muscle are, approximately where it starts and finishes, and then using resistance applied from yourself as a therapist or as a PT, you then tend to find you're able to reproduce symptoms by activating the muscle and obviously stressing the tendon. Now, this word crepitus, which means clicking and popping, which is what a lot of people come into the clinic complaining of, my shoulders click and pop, my knees click and pop. That's different to the crepitus that I'm talking about as far as tendinopathies are concerned. Crepitus in tendinopathies occurs in those tendons that we talked about earlier, where they have a tendon sheath. So when you've got tenosynovitis in your hand, in the extensor tendons of your hand, when you make a fist with your fingers, you can actually hear a creaking sound taking place in the tendon. And it's the tendon sheath adhering to the tendon underneath which causes that crepitus. Same in the feet. So again, we've got another situation where we've got tendon sheaths around the tendons of the toes. So again, when you make a fist with your foot, you scrunch your toes up, again, you can hear an audible crepitus, which is again like a creaking sound created because of the adhesions between the tendon sheath and the tendon itself. Now, the Achilles is another one that's got a paratenon. So this is another type of sheath. And again, you can get creaking that takes place when you've got Achilles tendonitis badly. So crepitus isn't always present. When you've got lateral epicondylitis or tennis elbow, golfer's elbow, supraspinatus tendonitis, you won't get crepitus. If you've got a client that's presenting with pain in their wrist, back of the hand, top of the foot, that crepitus might be present because it's the tendon sheaths that are inflamed as well as the tendons. Now, typically, I wouldn't use imaging unless I've got a really chronic tendon problem that I'm worried about rupture. So ultrasound imaging is the best, the gold standard as far as images are concerned. You know, MRIs don't show enough of the detail of the actual tendon. So occasionally, if I'm in a situation where someone's had a tendon problem for a couple of years, their load tolerance is very low, and I'm worried about rupture, I might refer them on for imaging. But generally speaking, the clinical signs, the pain on palpation, pain on manual muscle testing, with or without crepitus, those are usually enough to be able to make a definitive diagnosis. Now, this is a relatively new theory, the donut theory, and the general consensus of opinion is that with tendons, when they start to disrepair, there's a part of the tendon, which in this case is the hole in the donut, that becomes pathologized. So essentially, there's a focal point of the tendon problem, and that's the hole in the donut. Now, the general consensus of opinion is that hole is probably always going to be there. So no matter how much eccentric work you do or isometric work you do, that dysfunction in the tendon is probably always going to be there. However, the general consensus of opinion is if you treat the actual donut, i.e. the rest of the tendon, you increase the cross-sectional area of the tendon and you increase the loading capabilities of that tendon so that you can bypass that little bit of an area that's dysfunctional. So the donut theory is about treating the donut, the outside bit, and not worrying about the hole in the middle, because the body will lay down scar tissue and repair that in its own time. But in terms of making your tendon able to tolerate load, treat the donut, treat the outer bit. Now, there's two terms there, the reactive stage, which is coming from the Cook and Purdon paper. This is the itis stage of tendon problems, and there's this concept of stress shielding. So in the early days of a tendon problem, when it first becomes symptomatic, for a lot of individuals, if they simply just laid off their training for a couple of days and gave the tendon a chance to repair, that would get them out of that first stage of tendon degeneration. That would stop them from moving into the disrepair or degenerative stage. Once you get to the disrepair degenerative stage, then the only way to address these tendon problems is by reloading the tendon back up. So you tend to find that's where we start to talk about isometric exercises, that's where we start to talk about eccentric loading, that's where we might start to use things like blood flow restriction training, all of which we're going to talk about in subsequent slides. Now, from a management perspective, and this is probably going to piss off a lot of the manual therapists out there, from a passive, so the difference between passive and active, passive treatment is what I would class as massage, acupuncture, instrument-assisted soft tissue massage, foam rolling, stretching, cryotherapy. These are things that you would do to your clients or get your clients to do to themselves to manage the symptoms. Now, the majority of these, there's a lot of knockers of manual therapy, of hands-on work, of passive treatment. And their contention, I suppose, is that this is a short-lived effect. So, you know, your massage doesn't last long, your acupuncture doesn't last very long, your instrument-assisted soft tissue massage doesn't last very long. And what I'd say to the knockers of manual therapy, from my perspective, and probably from a lot of the therapists out there, is this gives me an opportunity to see, when I treat somebody, if they are pain adaptive or non-pain adaptive. And what do I mean by that? So pain adaptive, when I've treated somebody and their pain has subsided, maybe they were a 6 out of 10 on a visual analog scale, which is a scale we use to measure pain clinically. And when they leave the session, they're a 2 out of 10. That tells me that client is pain adaptive, and that a combined approach of some manual therapy and an active approach using exercise will work really well for that individual. If on the other hand, I've got somebody that I treat and they get up and they're a 6 out of 10 when they walk in and they're a 6 out of 10 when they walk out, those people are non-pain adaptive. So they're the ones that you wouldn't use your passive treatments with, you know, your massage, your acupuncture, your tool massage, your stretching. because in those situations, in those individuals, for whatever reason, their central nervous system, the pain pathways don't respond to that form of treatment. So passive treatment, this is about managing symptoms. It's about managing pain. It's not necessarily going to reload the tendon back up. Rest. Now, unless you're in the reactive stage, the very early stages of a tendon problem, and this isn't generally what I see when people come into me, they've had it for months or if not years, rest is one of the worst things you can do from a tendon perspective. Because when you rest, your tendon actually degenerates further. So all of you out there doing your home workouts, what you're actually doing is maybe not building or maintaining muscle, but what you are doing is protecting your tendons for once the gym's open and you can go back to lifting, reasonable loads. So look at if you look at some of the other examples, footballers, they have the 6-week break, they come back after the 6-week break. Injury rates in pre-season training are really high. And that's because during that 6-week break, when they probably haven't done much in the way of physical activity, their tendons have got softer. So rest actually causes tendons to degenerate further. So what should you be doing? So from an active approach, this is the exercise side of things. We're going to talk about isometrics, eccentric loading, or heavy slow resistance. And these are the modalities that you're going to use, whether you're a PT or a therapist, to try and address those issues in the tendon. Now, an isometric contraction is when there's a load, but there's no change in length in the muscle. So for those who are unsure about that. These work really well in the acute stage of an injury. So when your patient presents or your client presents and they've got that hot, squealy tendon, using some isometrics to produce an analgesic effect, that's a pain relieving effect, works really well. Now this isn't tendon specific, you can't apply this approach to all tendons, but trying some isometric contractions, 5 seconds, times 5, and that might be done as one bout of exercise or it might be done as 5 bouts of exercise throughout the course of the day against a challenging load. That works really well to provide an analgesic effect, but more importantly, it starts the process of tendon loading up. And that's the thing we've got to do. We've got to take that more pliable tendon and we've got to make it stiffer so it can handle load better. Eccentric exercise, so this is essentially where you are concentrating. PTs, you might know this is the negative part of the movement, so you've got the positive and the negatives. This is where you are loading the muscle and the muscle is lengthening under that mechanical load. Now, from a research perspective, we know that eccentrics alter tendon metabolism and the mechanical properties of those tendons. So what you're doing by doing your eccentric loading is actually changing the cellular structure of the tendon. In terms of dosing, the jury's out. I mean, I tend to start off with my clients when I'm doing eccentric training. I tend to start off with a low load and high volume. They might be doing 12 to 18 reps, 3 to 5 sets. And I do that because what I'm trying to avoid, because when you're into the stage of using eccentrics, you are probably in the degenerative stage of the tendon. And I think if you load that tendon up too quickly, there's a danger that you start to cause or create the potential for rupture. So I probably use a conservative approach when it comes to dosing. So starting off, light mechanical load, using volume, set some reps to achieve the dosing in that situation. And then as you get further away from the initial bout, that initial consultation they came in, I then tend to increase the mechanical load and reduce the volume. So then we start to move into the kind of 6 to 10 rep range and maybe again 3 to 5 sets, whether that's done as one bout or periodically throughout the course of the day. Now I think it's worth mentioning at this point that it's not a one-size-fits-all approach with tendons. You tend to find that not all tendons respond well to eccentric training. In that situation, the isometrics work really well. What you then want to try, so if you've tried eccentrics and they haven't worked, it's actually made your patient symptoms or your client symptoms worse, you then might try a heavy slow resistance approach, which is basically using the concentric and eccentric part of the movement of your exercise that you're using and not specifically isolating the eccentric component like you would do with eccentrics. So before we move on to questions, I'm just going to summarise what we've said. So managing tendon problems is all about managing load. If we can stress shield a tendon, so in the early stages of an injury, if we, the first presentation, that first ache that they get, if we can offload that tendon for a couple of days, allow the tendon to recover, you'll probably prevent your clients or your patient from entering into the disrepair and the degeneration stage of that tendon continuum. Once you pass that stage where rest hasn't achieved what they wanted to do, and when I talked about rest, here we're talking about a couple of days rather than a couple of weeks, which is more common. We then move on to isometrics. And we use isometrics because they offer an analgesic effect, and generally because they're done in the mid-range of movements where the muscle is maximally overlapped, you tend to find there's less likelihood or less chance of that tendon, if it is very, very degenerative, rupturing. So that's your isometrics. 5 times 45 seconds with a challenging load, and that should be enough to start to load the tendon back up. And it should also offer that analgesic effect. Eccentrics or heavy slow resistance. So once you've passed the point where isometrics are useful, you've controlled your patient or your client's pain, and you're now in a situation where they've got less pain day to day, they've got less pain when they're doing the sessions in the gym, you then start to move into eccentrics or heavy slow resistance. Now, the thing to note here, which I didn't mention previously, is that you often find with your clients, they'll get worse before they'll get better. So in this situation, expect them to have, 2 or 3 days, maybe up to a week of increased symptoms. And that will settle, and they don't need to take, any anti-inflammatories or stuff during the course of that process, because it's the tendon starting to go through its repair process. There's been lots of research where they've talked about tendons failing to heal. And I think in that situation, the tendon, which has probably been trying to heal for months or years, it's given up. All of a sudden, you start to load it eccentrically. It stimulates the tendon, the tenocytes, the things that lay down collagen in tendons, to then start to lay down more repair tissue. And then the final point, it's about activity modification, not rest. So therapists out there, rest is the worst thing you can advise for your clients, even in those acute stages. Modify their activities, get them loading as soon as you can. And again, PTs, same situation. Work around it for a while whilst it's in its acute stage. But then once you've controlled those early symptoms, you then have to go through this reloading process. Right, guys, so I'm just going to get rid of my screen share. Stop share. And I'm going to see if we have any questions. So there's some things flashing up here. Yeah, so the hip is equally prone to tendon issues. Yeah, I think the hip is equally prone to tendon issues, but I think those tendon issues come as a result of compression rather than tendon overload. So I think in the hip, particularly if we're talking about hip flexors and the glute med, glute min, I think in those situations, tendon problems usually arise as a result of people's, hip hinging, leg loading exercises, leg pressing, squatting. And it's the compression of the tendon rather than the overload of the tendon that starts to cause those hip problems. Can you test between a sheath or a tendon? And if so, what area of the body is the best to test? The only way you can tell between whether it's a tendon sheath, so it's a tenosynovitis, versus a tendinopathy, is the presence of this crepitus. So this audible creaking sound that you tend to find happens with tendon sheaths. So there isn't a specific way to test whether it's the sheath or the tendon, other than the fact that if you've got audible crepitus, so you've got some creaking taking place when you make a fist or you scrunch your toes up, that usually indicates it's the tendon sheath rather than the tendon itself that's become dysfunctional. And again, you'd manage that in the same way. Any other questions, guys? Yeah. Repeat the difference between a slow heavy resistance and an eccentric load. Yeah. So with eccentric loading, let's say we're doing an Achilles exercise, we're doing a calf raise with a specific focus on the eccentric component. You'd raise upon both legs. So both legs and the gastrocnemius and soleus are working concentrically. And then when you get to the top of the movement, when you're on your tiptoes, you're going to lower down on the injured side. So it's the injured leg that performs the eccentric contraction. Both legs raise up, the injured leg lowers down. So in eccentrics, we're isolating and trying to work on the eccentric component of the movements. We're trying to reduce the load concentrically on that tendon. When we talk about heavy slow resistance, we're talking about the concentric and eccentric components of the movements having equal value. So we're working both concentrically, eccentrically on the injured side. We're not taking the concentric components out like we would do with the eccentrics, and that's the main difference. I hope that's answered your question. Jasmine, if you suffer with tennis elbow, are there any exercises you recommend to start building back up? Yeah, absolutely. I think if you're in the acute stage of a tennis elbow, a lateral epicondylitis, you can buy these little splints, tennis elbow supports, where you've got like a Velcro strap that goes around your elbow with a little rubber ball that attaches or inserts just underneath where the tendon attaches, and that will give you some symptomatic relief if you're in the reactive early stage of the injury. Once you've got out to that point, you then want to get onto, so let's say you're at home doing this, you've got access to a dumbbell, and you've got access to a chair or a bench. You'd let your wrist drop off the edge of the bench on the injured side with the tennis elbow, and using your good arm, you'd raise the wrist up, so you'd raise it into an extended position, and then with your bad arm, you'd lower that weight down back to your starting point, and you keep repeating that process. So that would be an example of your tennis elbow. I'm trying to keep up with the questions before they all go. Do you still believe in ice, contrast bathing alongside isometrics and acute phase? So I don't tend to use ice, and this is probably a debate for another webinar. In my opinion, when you've got through the inflammatory stage of a tendinopathy, which we talked about is often asymptomatic, there's very little point applying ice to the injured area, other than the fact that it might give you some pain relief. So if you're looking for pain gating, to distract your brain from what the tendon feels like, then ice is very useful. In terms of actually doing anything to the tendon, I think it actually slows the tendon repair down, because what you're actually doing is you're reducing the diameter of the blood vessels, you're reducing the permeability of the blood vessels, and as a result, you're slowing that healing process down. So personally, if you use ice from a perspective of you're trying to do something cellularly to the tendon, then you're wasting your time. If you're doing it from a pain relieving perspective, then yes, ice or heat works equally well, because what you're doing there is you're pain gating, which again is another concept that gets talked about a lot in therapy. Right, next question. Does the treatment change with tenosynovitis and tendinitis? So no, the treatment approach, whether you've got a tendon sheath inflammation or whether you've got a tendon inflammation, the treatment approach is essentially the same. Start with isometrics because that's what's going to give you some analgesic effect and start the tendon loading process, and then you move on to your eccentrics or your heavy slow resistance. So no, it doesn't matter whether it's a tendon sheath problem or a tendinitis. Someone said, thank you. Thank you. I have a question in regard to a client, semi-pro footballer. No pain, no activity of daily living pain when running in Achilles tendon only pain when striking the ball and back to normal, very minimal pain on the Achilles tendon palpation. So I think primal clinic, this is obviously Karan. I think from a tendon loading perspective, you think about striking a football, there's a high amount of force going through the foot as you strike that football. I would argue that the reason he's still getting some pain when he's striking the ball is because he hasn't taken his rehab far enough into the kind of eccentric loading stage to actually fully address that tendon disrepair. I think the other thing you've got to think about with eccentric training, if we think about things like plyometrics, which again is another form of eccentrics, a lot of sports people and a lot of therapists and PTs don't include plyometric training as part of their rehab. And I think that we're missing a trick by not doing that. So I would be inclined, once you've gotten through a normal tendon loading program using your eccentrics, start to increase the speed of that eccentric contraction using plyometrics, jumping, bounding, hopping, and also increase the magnitude of that force, again, by using your plyometric type training. I think that's why he's still having pain when he's kicking the ball. Next question is from Joshua Holmes. I suffered a partial rupture of my triceps. Would you recommend to follow similar steps? Yeah, so I think, again, this is all said without seeing you as an individual in front of me and doing my own assessment. Yeah, essentially, if you're trying to rehab a tendon rupture or partial rupture, you would want to follow a similar process. So starting off with the isometrics, then moving into your eccentrics using a low load, high volume approach in the early stages, and then moving from there into a higher mechanical load, lower volume approach as the tendon becomes stronger. I think one of the things that I tend to find with ruptures is the use of blood flow restriction, which we haven't talked about. I don't know how many people are aware of blood flow restriction or occlusion training. Blood flow restriction from a rehab perspective works really nicely because you'll find when you occlude the limb that you're working on, so you're reducing the venous return of that limb, the metabolic stress that you accumulate with a very minimal load is what starts to create the tendon and muscle hypertrophy. So you can get away with as little as 30% of your 1 rep max, if you like, when you're blood flow restricted, and that will have the same effects as if you were mechanically loading it at 100% of your 1 rep max, unoccluded, because of the metabolic stress effect of blood flow restriction training. That might be something that we do another webinar on, blood flow restriction training and rehab or hypertrophy. So I hope that answered the question. I'm just going to come down a little bit. We've got 5 more questions. I'm conscious of the time, guys. I'm going to whiz through these. Peace and love is the new approach for tendon injury. Okay, yeah. Let's see how that works out. What would you be approach? Okay, so what would be your approach in using blood flow restriction training with patellar tendonitis? Would you prioritize any particular loading in terms of short, mid, and length and position? So I use blood flow restriction training a lot with my patellar tendonitis or tendinopathy clients, because when they are in that acute stage, when they've got to the point where they've decided it's bad enough they're going to come and see me, they're usually at the point where they're going up and down stairs, and that's causing them knee pain. Now, to suddenly embark upon a heavy eccentric training program in that situation is just going to exacerbate their knee pain 10 times. And it means they're not going to be compliant with what you're asking them to do. So in those situations, what I found works really well is that blood flow restriction training. Now, you can buy occlusion cuffs relatively cheaply online, or if you don't want to venture down the Amazon route at this point, and you've got some knee wraps work exactly the same way. Now, the difference between an occlusion band and a knee wrap is the occlusion band, you've got a pressure dial, so you can actually pump the cuff up to a certain millimetre of mercury of pressure, so it makes it a bit more reproducible. But in terms of your knee wraps, we'd use that visual analog. So if 10 was as tight as it could be, we'd wrap to about a 6 or 7 on that visual analog scale for tightness. And then what I would tend to do in that situation would be to reduce the depth of if it was a squat movement or a leg press, I'd reduce the range of the movements. So we're not loading the tendon, so the tendon isn't maximally loaded and maximally stretched like it would be in the bottom position. And then I'd gradually reload them back up, increase in load and increase in range as we get through the latter stages of the rehabilitation process. Next question. So another one from Primal Clinic. I have a question in regards, we've done that one. That's a repeat. Zach Gondalis, tendonitis, tendinosis, tendinopathy. We've talked about that, Zach. Go back to the previous few slides. Audio's gone.
Aaron.
Go on.
Yeah, I just meant like in terms of the actual approach. Will you change if somebody comes to you with tendonitis, or is they coming more in the degenerative way, or is actually a pathology? Will you change the approach in terms of how to use the blood flow restriction, or will you do exactly the same thing?
I would. The thing is, you don't know. So when they come in to see you, you don't know whether in a tendonitis, a tendinosis, or a tendinopathy. Tendinopathy is the blanket term we use to describe both of those conditions. So you don't know which one they're in. So essentially what you would do, you treat them the same way. You use your isometrics to reduce pain in the early stages, whether active or degenerative stage, and then start to gradually reload it up. The only caveat would be if it's somebody that's had a tendon problem for a couple of years, there's probably going to be a lot of degeneration present in that tendon, which makes the tendon weak. So I'd be cautious in that situation about going straight into or heavy slow resistance because of the risk of tendon rupture. I'd be very cautious in the situations where people have had tendon problems for a number of years, just for that basis. But isometrics, first protocol, eccentrics, but just reduce your mechanical load in those people who are at it for a period of time. Use your volume to increase the training stimulus. And then as they get further away from that initial bout of pain, then you can start to increase the mechanical load from there. Generally, if you can get a tendon to about 50%, it can tolerate about 50% of their body weight, if we're talking lower limb. That tendon tends to, the degenerative process tends to reverse, and then people then start to recover. So we're not looking at maximum loading tendons to help them to initiate that repair process. We're looking about 50% body weight, and that stimulus seems to have the optimum effect. Is that right for you, Zach? Perfect.
Yeah, that's perfect.
Next question. Let's see if I can get this one up. I referred out working on sports physio, and it's just not to get the client to do rehab exercises themselves, ACLs, you repeat your looks these and go about these on my client, program. Yeah, so I think the question relates to clients adhering to their exercise programs, their rehab programs, alongside their normal exercise programs. And I think, as you've already identified, sometimes trying to hide your rehab exercises within the context of your normal training plan works really well. So what I tend to do with some of my clients that are resistant to being adherent with their exercises is I make it part of the warm-up. So I'll actually program a warm-up session where they do a lot of the rehab stuff in that warm-up session, and I tell them it's going to activate and mobilize and improve the session afterwards generally. Or I'll take over the programming for that particular body part completely, and I'll put my own session together for them. So I actually prescribe, if it's a lower body exercise or it's patellar tendonitis, I actually give them a lower body session, which is going to specifically target the tendon problem, but also manage their desire to hypertrophy muscles or whatever the goals are. So I think hiding things in programs works really well. Hiding your rehab exercises in amongst a normal programming session. And if they're still resistant to changes, then you tend to find actually programming the session yourself for them. So saying, right, this is your lower body session, or this is your push session, or this is your pull session, depending where they've got problems, which tendon they've got problems in. Right, next one. Okay, great, Barona, thank you. Try and keep in touch. Thanks, Kyle. So what is the significance of scapular dyskinesia and shoulder tendon injury? Will you work on correcting the dyskinesis, or will continue loading the tendon as usual? So scapular dyskinesis is basically an alteration in something called the scapulohumeral rhythm. So when your shoulder blade moves and your humerus moves, there's a 2-to-1 ratio of scapular movement to humeral movement. Now, when we see shoulder problems, and you'll see this in your clients, when they've got one shoulder that's up, it looks like their upper traps are super tight on one side. That's a sign they've got some scapular dyskinesis. There's some alterations in the way the scapula is moving. So it's not an asymmetry. It's not something that they can correct by stretching out the traps or doing whatever it is that you'd normally do to correct that imbalance or that asymmetry. What they need to start to do is to build some strength in the scapular stabilizing muscles. So it's things like serratus anterior, middle and lower fibers of trapezius. You might do some stretching or inhibitory work onto the upper traps to get them to fire less quickly. But what I would do in that situation, I would work on the scapular dyskinesia alongside the loading of the tendon. I'd try and include two things as part of the same process. Because if they've got scapular dyskinesia, you tend to find that their shoulders up here, there's much more likely them pinching that tendon. So if you're just reloading the tendon back up and the scapula's not moving effectively, you will find that that's just going to continue to impinge on that tendon, still continue to cause them problems. So I would work the two things in at the same time. Right, next question, Emily. Can occlusion bands, blood flow restriction be used on the calves to help with the Achilles tendon, or should it be just rouged around the knees, quads and biceps? I think unless you have peripheral vascular disease, or you're diabetic, or you've got some issues with circulation, I think it's absolutely fine to use occlusion bands or knee wraps underneath the knees, around the top of the calves. I don't see any more problem using them there than I do around the biceps. You know, it's a similarly small muscle, or at least my calves are similarly small. So I don't see any problems at all using blood flow restriction bands or knee wraps underneath the knee, around the top of the calves. As I say, as long as you haven't got these peripheral vascular diseases. Right. So just coming up to 1 o'clock there, guys. So I'm not going to keep you too much longer. Thank you very much for your attendance. I hope that was useful. As I said at the start, if you could give us a shout out on your social media pages, that would be much appreciated. If you're interested, we have a closed Facebook group, which you're all welcome to attend. So you can either message us on Facebook or DM us on Instagram, and you'll have access to a wealth of knowledge there from PTs and therapists alike. So you can pose questions there. If anybody's got any other questions, direct them into the Facebook group. Thank you very much for your attendance. There will be another one of these running probably next weekend again, if you found it useful. So if you've got some ideas of stuff that you want me to go through, drop us a message on the Facebook group, and I'll do my best to put together a presentation and try and make it as interesting as I possibly can do. Thank you very much. Have a good rest of the day.